thanks very much. It's so great to be here with so many dynamic people doing so much. I'm really honored to be in the company. I want to also applaud Professor Alan Crandall on his humanitarian award this year. But it's really just great to be here with everybody. I'm going to speak a little bit in line with what Lisa was just saying on what we're trying to do. And I really think that the key thing is the cooperation. And there's so much blindness, and we really need to work together. And our whole focus has been trying to overcome needless blindness through really developing the infrastructure, and really through training and establishing a system of eye care delivery, but really quality training and quality overall ophthalmology.
I'm trying to unlock what is the solution to this unbelievably large burden of global blindness. And as you heard, it's really, I think, a travesty that we were left off of the UN Millennium Goals. And that's one of the things I think needs to change in the next few years. And Lisa said about low vision, of those 246,000 people with low vision, it's about 33% cataracts and around 40-some% refractive error. But when you look at blindness, it's almost 50% worldwide are from easily treatable cataracts. The glasses can be distributed, and in Asia it's much higher than 50%. And I've been very fortunate. I use, we talk about the Himalayan Cataract Project, but I've been working for 25 years with Dr. Sandak Ruid, who many of you know from Nepal. He's the real kind of genius behind anything we've been able to accomplish. I was very fortunate to do my fellowship with the Fred Hollows Foundation in Australia. I came over, and Fred, those of you who don't know him, he unfortunately passed away in 1993, but he was this curmudgeon who kind of bowled for exactly what he felt was necessary. And he had mentored Sandak Ruid. I did my fellowship in Australia. They sent me over to work with Dr. Ruid. And I was absolutely blown away by Sandak when I first met him. He is one of the most brilliant people I've ever met. When you think about brilliance, not just in terms of innovating eye care and thinking of new instruments, but also in terms of seeing the overall picture in the system, but also having that social brilliance to be able to recognize talent, nurture talent, and really get things done. And he already developed a wonderful system of eye care and eye care delivery where no one does anything with a skill that someone with lesser training can do. So we don't have trained nurses putting in eye drops and really figuring out how to stretch the skills of the doctors. He had trained at the All India Institute of Medical Sciences in Delhi, and retrained in the Netherlands, and then Australia. He did a 2-year fellowship with Dr. Govinda Swami at Tabin, and came back and brought this system to Nepal. As you've heard, there's really not much we can do more for real meaningful impact than transforming the lives of families with sight restoration. You heard some of the statistics from Lisa. We know 90% of the blind live in the developing world, and the devastation of what it does to a family. And we really need to get out to our world leaders that blindness really does perpetuate poverty. But one of the things we also see is that poverty magnifies the social and personal impact of being blind. When you're blind in the developing world, it's a huge burden. That 4-to-1 ratio, the Himalayan Cataract Project did that study along with the Fred Hollows Foundation, showing a $4 return for every dollar invested in eye care. But that does not include the indirect costs of this young child who will not be able to go to school, and the lifetime earnings of this child when he goes back into his village after his father passes away, what his income will be different because he couldn't go to school because he had to take care of his father. And the indirect costs of an elderly person coming back and providing child care or providing cooking or cleaning. And there's about 2.5 people lost to the workforce for every blind person in the poorest places. And the cost of this world economy is $47 billion every year. And the other thing that doesn't get mentioned is that the lives are shortened. Once you go blind in the developing world, your life expectancy is 1/3 that of an aging health-matched peers, and for children it's much, much worse. Now, most of the children who go blind still, as you all know, are from nutritional issues, vitamin A deficiency. And these are the same kids with primary protein deficiency, the same kids who have kwashiorkor, the same kids who are more susceptible to dying from malaria or tuberculosis or pneumonia or diarrhea. But when you look at these same kids, the ones in these poorest sectors with their little armband, you find their level of malnutrition. The blind kids die at an alarming rate. And we all know what these cataracts look like. They cause blindness. And one of the other things that doesn't really get talked about much, and this is a bigger problem, I think, in India than a lot of other places, but also certainly in China, but it's also emerging wherever cataract surgery gets really good. Because quality drives the demand. It brings the poor people in. But the problem is that there's now this burgeoning middle class, upper middle class, which is not a problem, but there is a burgeoning middle class and upper middle class in a lot of countries, in India and Indonesia. And those people want to have their cataracts done not when they're blind, but when they're 2,200. And all of a sudden you're looking, operating when people are 2,200, we have 60 million cataracts we have to perform. And 60 million cataract surgeries we have to perform. And if you start operating where we operate in America, and I often have operating days where nobody's vision is 20/60. I'm operating at 20/40, 20/50, 20/30 PSC. If we operate 20/60, it's 8 times that number. And the people who are driving a cab in Delhi want their cataract fixed. The people who are working as an engineer in an office and their vision is 20/60, they want to have their cataract fixed. And the quality is now so good in India that people are coming early for their cataract surgeries just like they do here in Washington, D.C. So what is a feasible and proven way to do things? It's really developing a system that really stretches the skills of the doctors. The other thing we've been focusing on is reaching the unreached. How do we reach the remote communities? When you have an agrarian society like Ethiopia, you have about 105 million people in Ethiopia. There are about 90 operating surgeons in Ethiopia. About 60 of those are in Addis Ababa. But 85% of the population is rural. And how do you reach those people? So what we're trying to do is figure out how do we deliver surgery in a very high volume. And I don't want to emphasize surgery because we called our program the Himalayan Cataract Project because when I started working with Sanda Gruid in Nepal, we began kind of training just the first doctors to do cataract surgery, do better cataract surgery. Then we took our young, good cataract surgeons, sent them to America or Australia for subspecialty fellowships. And once we had a full component of subspecialists, we founded a full residency program at full American standards. But concomitant with that, Dr. Rui had that great foresight to start a program to train ophthalmic technicians in a 3-year program after high school, ophthalmic assistants in an 8-week course after 8th grade, and train really high-quality ophthalmic nurses in a 1-year course after nursing school. So really developing this sort of whole system, and we developed the subspecialists and then began really expanding. But we called it the Himalayan Cataract Project because at that time there were 250,000 people blind from cataracts in Nepal. There were about 60,000 new people going blind every year. And Nepali surgeons were doing only 15,000 cataracts a year. So it seemed absolutely overwhelming. And then you look at Bhutan, 0 cataracts with lens implants. Look at Sikkim, 0 cataracts with lens implants. Northern Pakistan, 0 cataracts with lens implants. So Tibet, 0 cataracts with lens implants. So we called it the Himalayan Cataract Project. And what we began doing, in addition to doing the training, was really looking at best practices. And these are just some of our peer-reviewed articles that have come out looking at how we're doing the high-quality care and really having low complication rates. And the quality really is followed by, the demand follows the quality. And even the poorest of the poor recognize quality. So the biggest emphasis that we had initially in the Himalayan Cataract Project in Nepal, again working in Bhutan, was really focusing on absolute quality for every patient we cared for. And these are again more of our peer-reviewed articles showing the low infection rate and our cost effectiveness in reaching the population and the really excellent outcomes. But we really began developing a system with primary eye care centers dotted through the hills of Nepal that were staffed by these 3-year trained ophthalmic technicians, 1 year after nursing school ophthalmic nurses, and referring to cataract centers and then our main training hospitals. We now have subspecialists at all of the major hospitals throughout the south of the country, and blindness has actually dropped in Nepal. These are published studies. 1984, the blindness prevalence was 0.84%, 2012 down to 0.35, and we're just finishing a study that's going to show we're down to about 0.23%. And similarly, the rate of cataract surgery has gone up from 15,000 to, by 2015, 300,000. And the quality is uniformly wonderful. And a lot of our sustainability is now coming from people who are actually coming from other countries. Many people are coming from Bihar and West Bengal and areas of China into Nepal because the quality is so good. So the next question is now, how do we scale what we're doing? We've spread fairly seamlessly over the last 25 years from really working and training in first Nepal, then we moved into Bhutan. As we're trying to scale, we're looking at where should we go? Well, the big places is a map from Andy ASCRS from Kenya, and this shows where the prevalence of blindness exists. And you can see that Africa is a nice fat-floated continent, but when you look at where the practicing ophthalmologists are located, you can see Africa is this shriveled little stick, about 1 per million in sub-Saharan Africa right now. And so we're trying to figure out how can we take our, it's been so successful in Asia. And we have several very great successes in other places in Asia as well. We're teaching in several other countries. But how can we bring this to Africa? And one thing that helped us in terms of sustainability in Asia, when we started working in Nepal, 80 to 85% of the blindness was from cataracts. And about 90% or 95% of the blindness or low vision was from cataracts or refractive error. So we had instantly a fairly good cost recovery model. Before Dr. Rui, the elite of Nepal all left the country. They'd go to Delhi for their cataract surgery, or they'd go to Hyderabad or Mumbai. And if they had more money, they'd maybe go to Europe or America. As soon as Dr. Rui came, we started getting the cost recovery of having the elite coming, and it created a system where people were expecting to pay for surgery if they could. And it really was sustainable. But in Africa, less than 50% of the blindness is from cataracts. There's a much higher incidence of glaucoma, as we all know. There's a much higher incidence of infectious blindness. There's a high incidence of retinal blindness, and less than 50%. So if you're going to carry your mom on your back for 3 days to reach a facility, and there's a 4 in 5 chance of a miracle, and she comes back seeing perfectly the next day, other people are going to go on. Whereas if you have less than a 1 in 2 chance of a miracle, the disgruntled person who's taken 3 days out of the fields, not being able to feed their family and living in a subsistence day-to-day way, and you take 3 days out of the field, and mom comes back blind, it's not an incentive. Okay, from the place we're working, excuse me, our second program was thanks to Alan Crandall. When I moved to the University of Utah, Alan was already very actively engaged in his care in Ghana. We began working in Ghana and also in Ethiopia, which has one of the highest reported rates of blindness in the world. We also did a little bit of work in South Sudan, which is an overwhelming rate. And the big thing is really having partnerships, and all of the partners in the room today. But it's also been one of the things that really worked beautifully in Nepal, where Dr. Rui was able to bring together not only all the NGOs working in Nepal, but also all the doctors, and create a unified focus. And I'm really excited to say that in both Ghana and Ethiopia, that same synergy exists. We began working, as I said, in Africa, trying to bring this same way to move forward. And we're trying, one thing about blindness, it's one of the very few public health crises that we can win. And one thing that Lisa didn't say in that introduction, that beautiful introduction, talking about the other, things that did get the UN Millennium Goals, when you're treating somebody of a reduction in HIV and tuberculosis, malaria, those people are still a big burden to the system. You're keeping them alive with HIV, but they're getting a lot of other diseases. And we have one of the very few miracles where each individual person is no longer a statistic. They're 100% cured. And so our approach has really been, I've got to speed up a little bit, it's been really infrastructure and training as well as the direct service. And we use the direct service as a way of really doing the training. We do high volume cataract programs, but when we're doing that, we always have resident doctors. We always have people who are just out of the residency. And so it's really expanding, it's really teaching and really creating the skills in the people who are teaching the next generation. So we do a lot of direct service. We've now done over 700,000 surgeries in our program directly, but it's really when our equipment procurement person, Bill Shields, is here, who I think is second to no one in the world. He's working with a lot of these organizations, and those of you who need help with equipment procurement, Bill is really quite amazing. And trying to create a durable, sustaining infrastructure. And we estimate that it's about $100 million, which sounds like a lot, but it really isn't that much. $100 million to really reverse blindness in our main countries in Africa. And we're also looking at about, I've got to quit here, but about a $2 billion investment is what we're looking at as probably what it will take to really overcome cataract blindness, restore sight to everyone in the world, which sounds like a lot, except that's less than we're currently spending from the United States government on our wars in Iraq, Afghanistan, and Syria every month. So anyways, I'm going to stop this, just a video showing the joy of sight restoration. And it's been great seeing everybody. I've got an 11 o'clock flight to Addis Ababa, so I'm going to run. But thank you very much. I can be reached through our website, www.cureblindness.org, or Tabin at stanford.edu. And I think together we can overcome needless blindness. Thank you very much.